To finish block 4, last but not least, Professor Aaron Waxman. Professor Aaron Waxman is Director of Pulmonar Vascular Disease Group, Brigham and Women's Hospital from Harvard Medical School. Professor Aaron Waxman will address the topic long COVID and pulmonary hypertension. You use your own computer?
Yeah.
Okay. So, long COVID and pulmonary hypertension and other suspected cardiopulmonary comorbidities. My pleasure and a great pleasure for us to welcome you in Porto, Professor. It's yours.
Well, thank you so much. And as you can see, I changed the title, mostly because I've been hearing a theme of what is going on in patients with chronic fatigue and ME, as well as long COVID. But I'm going to now show you that this applies to a broad spectrum of patients, and there's a significant overlap. So bear with me. So what I want to cover is first the whole concept of dysautonomia on invasive CPAP, which you've heard a lot about already from both David and Rudolph. We'll talk a bit about the autonomic targeted therapies in clinical practice and how they actually apply well beyond these patient populations. I also want to talk a little bit about pulmonary hypertension, which I recognize that many people in the audience may not know much about, so we'll be very basic, but stress that it overlaps from an autonomic standpoint, and that some of the treatments we use for pulmonary hypertension may actually exacerbate some of the underlying autonomic dysfunction. And then we'll finish up with integrating really a comprehensive autonomic assessment into the patient population who have pulmonary hypertension. So to start, I thought a little introduction to pulmonary hypertension for those who are not aware of this disease. It is a rare disease, although it's not so rare when we think about the broad spectrum of patients who have pulmonary vascular disease. We define this disease hemodynamically. So we define it as a mean pulmonary artery or average pulmonary artery pressure being greater than 20 millimeters of mercury. So normally the pulmonary blood flow is up against a very low resistance, high capacitance system so that it can accommodate big changes in cardiac output without causing problems in the lung. We also define it relative to the pressure on the left side of the heart. A normal left atrial pressure should be 12 millimeters or or less. Generally, for the definition of pulmonary hypertension, we allow it to go as high as 15. And fundamentally, it's a disease of abnormal resistance or stiffness in the pulmonary vessels. And there, we want to see a low resistance system, and we define it for, it doesn't really matter the units, but a pulmonary vascular resistance of 2 Wood units or less. So very high flow, low resistance system. What happens in patients with pulmonary hypertension is that there's an abnormal cellular growth, proliferation, and fibrosis that result in stiff, constricted blood vessels. And that over time increases the resistance to flow, causes a backflow into the right heart, and the right heart starts to adapt initially and then maladapt so that it gets dilated, dysfunctional, and eventually fails, and these patients die from right heart failure. Just to stress that this is not simply a vasoconstrictive problem, but what you can see here in the upper right, up in here, is a pulmonary vessel that's well out in the pulmonary vascular tree. This is even further distal, and these are very thickened walls. You can see lots of cells there. Normally, these are very thin, compliant, and then allow for a lot of distensibility. What we've learned is, and this big conglomtion here, is the pathognomonic finding in patients with PAH, where we've got this disorganized cell collection that's reflective of this abnormal growth and fibrosis. And when we look closely, and this is part of the common theme across all of these diseases, is there's an infiltration of inflammatory cells. There's a robust inflammatory milieu or environment that probably drives a lot of this. There's also abnormal proliferation, and depending on where you are in the vascular tree, there's abnormal proliferation and activation of endothelial cells, and more proximal, like what you're seeing here, is there's also proliferation of smooth muscle cells. We've also learned that cells get bigger, probably reflective of both the physiology, but also just abnormal activation, which I think is a theme we've heard about today across the spectrum of endothelial cells in this disease. And then we've also learned that in pulmonary hypertension that there is abnormal differentiation of cells. So we can see connective tissue cells infiltrate into the lung and into the tissues of the lung and then transdifferentiate into fibrotic cells, making the whole process more stiff. Now, how do we treat pulmonary hypertension? This is way outside the topic here today, but right now I can just tell you there are 4 general pathways that we target with pharmacology. 3 of them are vasodilators, and we'll get back to that later. But you can see over here the 3 general vasodilating pathways. Prostacyclin pathway, because we know these patients are deficient in prostacyclin, which is a very potent vasodilator. The nitric oxide pathway, which biologically is our most important vasodilating pathway. And then the endothelin pathway, which we actually block because endothelin is increased in these patients, and endothelin is a potent vasoconstrictor as well as pro-fibrotic. Now, most recently, we've targeted the TGF-beta signaling pathway, and we heard a little bit about that earlier today. Here, this is part of the abnormal proliferation of these patients, and we can take out parts of this pathway so that it rebalances the system into a non-proliferative state, and we can actually now reverse some of the features of this disease. But again, this is outside of today's topic. So what is the paradox I'm talking about? Well, PAH-specific therapies, as I just pointed out, are generally pulmonary vasodilators, so they decrease that resistance in the vessels. The right ventricular function starts to improve as we decrease the pressure and the resistance. Yet, what you're going to see, and I'm going to show you a couple of patient examples, are that patients whose pulmonary hypertension is getting better still have persistent exertional intolerance. And this is where the overlap between this disease and what we've been talking about today settles. And the traditional endpoints, then, we always think about hemodynamics in these patients, needs to be adjusted once the hemodynamics are better, because in spite of good hemodynamics, these patients still have clinical limitation. So why might these patients still have exertional intolerance? Well, there are a number of reasons when we start to think about mechanism, especially when we want to start thinking about the autonomic nervous system. Peripheral chemoreceptors may be dysfunctional in spite of normal hemodynamics. The sympathetic nervous system plays an important role in the response to the abnormal physiology of pulmonary hypertension. But if we disrupt that sympathetic nervous system, as I'm going to show you, we can really screw things up. These vessels are abnormally stiff at baseline. And even though we're seeing normalization of their hemodynamics today, they still may have some abnormal responsiveness in those vessels, and there's probably sensation in those vessels that we have yet to discover that probably transmits some of their dyspnea. And then RV dysfunction, even though things have gotten better, there may still be under stress some abnormal RV function. And then skeletal muscle abnormalities, especially when we start to think about mitochondria. So fundamentally, exertional intolerance, no matter what disease state you have, is multifactorial, and hemodynamics is just one part of it. So getting to the autonomic nervous system, which, as I pointed out in the title, is probably fundamental in all of this. PAH is fundamentally an autonomic disease. Yes, it's a proliferative disease in the vasculature, but the response to that abnormal proliferation is activation of the sympathetic nervous system. And indeed, hyperactivation of the sympathetic nervous system can actually be detailed in patients looking at their skeletal muscle response and vasomotor response. And elevated sympathetic or muscle sympathetic nerve activity has been well documented in these patients. So really, autonomic dysfunction is compounding the vascular abnormality. And we can see that on a cellular and molecular level. In PAH, like many heart failure-focused diseases, we can see significant upregulation of the renin-angiotensin-aldosterone system. In fact, it's an important part of what we target pharmacologically. We can see upregulation of angiotensin 1 and 2 levels, which have direct effects both centrally and peripherally as far as activating the sympathetic nervous system. And part of our treatment paradigm for PAH is to actually try to block this system, more to target the kidneys and fluid management, and indirectly the sympathetic nervous system. So as far as if we do disrupt that sympathetic nervous system, as I've already mentioned, overactivation of the sympathetic nervous system really drives a lot of the response to PAH. And in fact, you can see a clear correlation of the activity of the sympathetic nervous system with patients' long-term prognosis. So it's really a form of compensation in these patients, and probably is a response to the remodeling that we see in the vasculature. In fact, what's being proposed in the world of pulmonary hypertension now is to ablate parts of the sympathetic nervous system in the pulmonary artery specifically. The concern many of us have with that is it's kind of ignoring the teleologic reason that the sympathetic nervous system is activated, and may actually not do a whole lot of good for these patients, but we'll find out from the clinical trials. So let me share with you a couple of patient examples of what all of this comes together as. So the first patient is a 60-year-old woman who was actually presented to a pulmonary hypertension center in New York, was diagnosed with pulmonary arterial hypertension. She was diagnosed by right heart catheterization, and she was started on treatment, which was 2 of the vasodilators that I mentioned. Now, in spite of treatment, she still had persistent chronic fatigue and exertional intolerance, and we also noted that she was hypoxemic, and her diffusing capacity, and for those who aren't familiar, diffusing capacity is part of a full pulmonary function test, and actually is a way of measuring the surface area of the lung that's involved in gas exchange. And typically we will see a DLCO or diffusing capacity reduce in patients with pulmonary hypertension because of the vascular disease. And if we think about the lung, the critical function there is to match ventilation with perfusion as best as the lung can. So here you have a disease that's involving the pulmonary blood vessels, and we typically do see some reduction in diffusing capacity. In her case, though, there was a severe reduction in diffusing capacity that was out of proportion to her pulmonary vascular disease. Well, we took her to the exercise lab. We did an invasive CPET to try to figure out what is the reason she's still symptomatic in spite of a good response to treatment for PAH. And we found out, and I'll show you her data because I think it illustrates, especially the 3 patients, that she had features that were consistent with dysautonomia. We took her to skin biopsy, and she had a small fiber neuropathy and was started on pyridostigmine. She got some improvement with pyridostigmine, and because of the skin biopsy findings, we also treated her with IV immunoglobulin, and she had a marginal improvement with that. But because the DLCO remained low, we took her to the OR and we did a lung biopsy. And her lung biopsy actually showed that there was deposition of C5b9 complement, which is an important part of the immune response. It was actually causing damage to her pulmonary capillary bed, and also, which gets to some of what we've heard from our colleagues in Stellenbosch, some abnormal clotting issues. So let me show you her data, because her response to treatment has been quite interesting and supports a lot of what we've been hearing about. So what you can see on this slide is the baseline is her right heart cath when we met her. So she's already been treated for pulmonary hypertension with 2 medications. They're down here. Ambrisentan is an endothelin antagonist, and tadalafil is a nitric oxide pathway stimulator or a phosphodiesterase 5 inhibitor, so upregulates the available nitric oxide. And what you can see here is that she still has pulmonary hypertension. Remember that mean pulmonary artery pressure should be less than 20, and her resistance is 2.5, so just really mildly increased. So I suggested at that time, double your drug, because this is half dose of both, and she went up to full dose, and 6 months later, this is her right heart cath. So it's normalized, and I'll show you the exercise data. Yet she's still symptomatic, still has exertional intolerance and chronic fatigue. And then 6 months or 12 months after that, you can see still has a pretty good looking right heart cath. So I'll show you what we saw. So that first right heart cath we did, you can see here, this is her exercise test. At peak exercise, she got up to 72% of her predicted maximal VO2. But what I want you to see here is what happens in her right atrium. These pressures, as you've already heard, should be over 6.5. They don't even come close to 6. Here's her mean pulmonary or her pulmonary artery pressure here, and this is the mean. It does get a little bit high, so she still does have some vascular stiffness, but really not impressive to account for the limitation that she had. So 24 months later, what we did was, because of that lung biopsy, we put her on a JAK inhibitor to try to block her complement activation that was causing the damage to her capillary bed. You can see here, though, she still has right atrial pressure that's low. And remember, she's on pyridostigmine and getting IVIG. The other important thing I didn't point out here is the mixed venous oxygen saturation. Remember, this should be down around 28%, so she's got a very significant abnormal oxygen extraction and probably is also generating a left to right shunt, as you heard from Dr. Systrom earlier. This is what happened before we started the JAK inhibitor. So this is all just really findings of dysautonomia at the same time she has pulmonary hypertension. And this is what happened after the JAK inhibitor. Really continued improvement in her pulmonary pressures. She still has significant preload failure and still has, but somewhat improved oxygen extraction. Once we started her on the JAK inhibitor, she actually started to improve significantly. So she's now able to walk significant distances and is actually now exercising regularly. And this is what happened with her diffusing capacity. We started the JAK inhibitor here, and we've been measuring her DLCO along with doing those CPETs, and you can see it's now, after several months, started to improve. So this is just an example of a patient who has an inflammatory disease state that is also generating the same physiology that we see in our patients with dysautonomia and ME and long COVID. Now, this is our next patient. This is a 25-year-old woman who came to us with a diagnosis of idiopathic pulmonary hypertension. When we met her, she was on 2 medications, both the same drugs you just heard about, but still significantly symptomatic because of PAH. Now, PAH we've always thought of as an inflammatory disease state. And this patient did not tolerate prostacyclin therapy, and she elected to go into one of our open-label clinical trials with a new medication, sotatercept, that targets that TGF-beta signaling pathway. As part of that study, she went through 3 series of invasive exercise tests. So these are her right heart caths, and you can see here that she had pretty significant pulmonary hypertension. Remember that PA pressure should be less than 20, and the resistance should be less than 2. 6 months after starting sotatercept, she's normalized her pressures, and yet still symptomatic. She's still complaining of fatigue and shortness of breath, but clearly not because of PH. This is 12 months later. This is a patient that we then did as part of the trial. This is her CPET data. And you can see again here, her right atrial pressure is profoundly reduced. And this is her baseline before we started sotatercept. And you can see here she's got a very significant oxygen extraction abnormality. So this is 6 months after sotatercept. She still has the same picture of preload failure. You can see that she still has significant oxygen extraction abnormality, but it's improved. And we've started her now on pyridostigmine after we saw this improvement. So now we're trying to target her dysautonomia. And here's her follow-up, and this is after 12 months of sotatercept, and she's been on pyridostigmine about 6 months. and you can see the right atrial pressure really doesn't change much. She has no evidence of pulmonary hypertension, but her oxygen extraction is starting to improve, and subjectively she feels markedly better. So targeting the sympathetic nervous system. And the last patient I forgot to mention though, her VO2 max also started to improve. This is our last patient that I wanted to share with you. This is a 66-year-old male who also came to us to go into that sotatercept study. He came in initially on some medications that we changed. He remained symptomatic, and by symptomatic, he remained a functional class 3, and then went into our clinical trial. I'll show you the data, but importantly, after about 7-8 months into the clinical trial, he actually contracted COVID. So what this is an example is a patient with long COVID. So these are his right heart cath data. This is his baseline before he went into the clinical trial. You can see he has very significant pulmonary hypertension. This kind of number would put him into what we would call the severe range. This is after 6 months of sotatercept and significant improvement. And then this is 12 months later, even more improvement. And it was in between these two studies that he contracted COVID. Now, this is his invasive CPET. This is at baseline. You can see here he does not have preload failure. This is fairly typical of what we see in a PAH patient, in that he has this big jump in right atrial pressure at peak exercise, which probably reflects an uncoupling of the right ventricular pulmonary artery blood flow. You can see here, too, that his pressure is still on the high side, and his extraction is excellent. Remember, I said this should be under 28%, and this is fairly typical of what we see in a patient with heart failure, and that they're just sucking the oxygen out of the blood. This is now 6 months later on sotatercept. His right atrial pressure is lower, but probably more reflective of our treatment of pulmonary hypertension. And you can see that at peak exercise, he does get up above 6. He still has significant pulmonary artery hypertension, and you can see his extraction is fine. So after this is when he contracts COVID. And this is what happens now 6 months later. You can see here his right atrial pressures have now fallen. And you can see he's still extracting nicely. He's got improved pulmonary hypertension, but he's really developed significant preload, and he was more symptomatic. We actually treated him with midodrine, which is an alpha agonist, so a vasoconstrictor, and it's been actually quite helpful to him symptomatically. So what's happened with all of these patients, because they all have a very similar physiology, and they all actually have positive skin biopsies for small fiber. So what we believe is happening, and why we think of this as an autonomic dysfunction, especially in those patients who have positive skin biopsies, if we think about the blood volume in the body, we can break it up into two big compartments. We have the arterial compartment, which holds anywhere from 25 to 30% of our total blood volume. The vast majority of our blood volume is sitting in the venous compartment, which we can then break down into 3 compartments: the muscular compartment, the cutaneous, and then the splanchnic. Now, importantly, with muscles, we obviously have muscles that contract and can act as pumps, as well as veins that have valves and a sure one-way flow. But obviously in the cutaneous and splanchnic beds, we don't have valves, and we certainly don't have muscles. So there's a propensity for blood to pool. If we look at these patients with positive skin biopsies, what we see is a dropout of the sympathetic neurites using sweat glands as a surrogate for vessels, and just a dropout of the density of these neurites, and essentially a loss of the signal to maintain venous tone. So this, we believe, is what's driving a lot of this. So we end up with splanchnic and cutaneous venous pooling, and the peripheral, which left to right shunting, which you've already heard about, is loss of regulation of these bridging vessels between arterioles and venules close to the capillary bed. And I think all three of these patients show various pieces of evidence for this. But why is this such an important issue with pulmonary hypertension? Well, in pulmonary hypertension, because of this increased resistance, we start to see the right heart dilate and try to compensate for this resistance, which means they become very preload dependent. And here we've got a bunch of patients with preload failure. So this is a normal conformation between the right ventricle and the left ventricle. Patients with pulmonary hypertension, we start to see this dilation of the right ventricle and even imposition and almost squishing of the left ventricle as the pressures really get significant. But even in patients with low pressure, we tend to see this kind of arrangement. It tends to affect diastole, so the filling of the heart becomes compromised, and they become very dependent on just the right amount of fluid. So there's really an optimal range of preload in these patients. And this just shows you the relationship of preload to really flow. And patients with too much preload, we start to actually push even more into cardiac distension, and it reduces function even more. Patients with too little preload, essentially the tank is not filled enough, and their pulmonary blood flow becomes much more dependent on heart rate rather than volume. And then really the optimal preload is somewhere between 8 to 10, 8 to 12 millimeters of mercury, so not too much, not too little, and it maintains enough forward flow that these patients actually feel better. So as far as pharmacotherapy here, I think you've already heard me mention pyridostigmine. There's actually been some small studies looking at pyridostigmine in PH patients, and the reason for using it in the patients I showed you is because they also had evidence of dysautonomia, and this being an acetylcholinesterase inhibitor should amplify that signal that is decreased because of the loss of the neurites. There's also some evidence that using beta blockers, something that's used frequently in POTS, may also have some benefit. So as far as patient management, I think the whole point to all of this is that patients with PAH or pulmonary hypertension in general, for whatever reason, are suffering from an inflammatory disease. The commonality across the whole spectrum is inflammation that probably affects endothelial cell activation. And that if we're really going to think about these PH patients, especially those who are persistently symptomatic, in spite of treating their PH, we have to think about autonomic function and how we can target that, how we can measure it, and even screen for pieces of autonomic disease. So to finish up, again, PAH certainly has features of autonomic dysfunction that we can't ignore. It's not just a vascular disease. Sympathetic dysfunction is really a critical determinant of their symptoms as well as their long-term prognosis. I think effective therapy in PAH certainly reduces pulmonary vascular resistance and improves heart function, but does not restore autonomic function itself. And that persistent symptoms, in spite of good treatment of their PAH, should be considered to reflect underlying autonomic dysfunction, and ideally that future PAH therapy will include that in the long term. So to conclude then, treating the pulmonary vascular bed without considering the autonomic nervous system is probably not a full management of these patients. And even though they improve hemodynamically, many of them will have limited function because of their ability to adapt to stress is governed by those autonomic mechanisms, and that too remains severely impaired. And so that the next frontier of managing these patients needs to include restoration of autonomic function. So thank you.